We'll go ahead and get started with the program, and I'd like to welcome you. This is Union Hospital, and we're going to present you a lecture called Dealing with the Pain of Opiate Abuse, and this will be myself. I'm the Chief Medical Officer of the hospital, as well as Dr. Daniel Cleveland, pharmacist and director of our pharmacy residency, and Dr. Randall Stevens, who is a family medicine physician and addiction specialist at Union in the Vigo County area.
Hey, doctor, can I interrupt a minute? Could everyone please mute their lines? Because we're getting a lot of feedback on our end.
Tell me how to mute from the computer, Cindy.
Okay, go to the very bottom and hover your mouse. You'll see a little strip pop up.
Yeah.
Go to the far left where the microphone is and just click on it. Did everyone do that? Okay, I think we're good now.
Okay, let's go. So the objectives today, we would like to relate the subjectivity of pain to the potential for abuse. We'll define tolerance, physical dependence, addiction, and pseudo-addiction. We'll identify the prescription opioid availability between states and recognize the national prescribing rates. We will cite healthcare, economic, and litigation costs due to opioid abuse, and help recognize the opportunity for education among healthcare providers, as well as determine risk factors for opioid abuse and methods to deter use. As you all know, pain is subjective, it's variable. Pain is described as whatever the experiencing person says it is, existing whenever he or she says it does. It's a quote from Margot McCaffrey, 1979. The subjectivity of pain syndromes lead to potential for abuse and diversion, and it's tragically ironic that while our streets are awash in prescription medications and undertreatment of pain is legitimate in patients remains a national problem. Senator Susan Collins of the Boston Globe said this. I think for physicians, this has become a difficult area. There's lots of physicians with all the state laws and all of the hoops they have to jump through to treat these patients. They're hesitant to accept these types of patients in their practice, so it's a real dilemma, and hopefully today we can help you walk through some of the problems and some of the ways to treat these patients. And I'd like to, just from a dilemma as a physician that's practiced as a hospitalist, admitting these patients to the hospital has become a real dilemma for many physicians. And the problem is, I can give you an example of a patient I had a couple of years ago that was in here 2 or 3 times. This patient was a female in her mid-50s that was admitted to hospital with just various complaints, nothing very specific, not really very ill, but one of these people that the emergency room physicians just weren't comfortable knowing what to do with. The patient was on 180 milligrams of OxyContin twice a day. She had been fired by essentially every physician in a 20-mile radius, including all of the pain clinics within an even larger radius. So deciding what to do with this patient when she comes to the hospital presented a dilemma, because if she's not really taking that much medication, you give her that much medication, then you're worried that she might overdose or have respiratory depression or even code in the hospital. If, on the other hand, she's really taking that much medication and you don't give it, then you're worried about the possibility of withdrawal. So this is basically an everyday scenario for emergency rooms across the country, for physicians admitting patients, and for physicians in private practice when they're coming into their office. So hopefully today will help give you a better understanding of what the problems are, definitions, as well as what are some treatment options for these patients. So next I'd like to introduce Dr. Randy Stevens, who's going to go in much more detail. Thank you.
Okay, thank you, John. This first slide that you see up here is just some definitions and tolerance. Well, this is the way I say that of all of us that are listening today or in this room, if we all have kind of bought into the things that have been shown that a nice red glass of wine every night will decrease our HDL for our cholesterol, and we have done that over the course of time, we're not feeling too much effect from that single glass of wine. If, on the other hand, you're a person who never drinks and all of a sudden you had a glass of wine today, you would probably have an effect from that. So over time, you can develop tolerance. You can take medicines on requiring higher doses, but that's the kind of tolerance. Physical dependence, I'll pick on one that everyone could relate to. If all of us had a serious, painful injury, and let's pick on a severe burn, something that required skin grafting, and we were on narcotic medicines for the next 2 or 3 months, that all of us, every one of us, if we suddenly stopped that medicine, would go through withdrawal. Doesn't mean that we're an addict, doesn't mean that we fulfill the definition of addiction, but we would all show that physical withdrawal. Addiction, on the other hand, is in this definition here, primary chronic. It's supposed to say neurobiological disease with genetic, psychosocial, environmental factors, including development and manifestations. What we're really saying there is that if all of a sudden we had 100 people and we prescribed a narcotic pain medicine to, I will say statistically 90 of them, they want to be off of that medicine as quick as possible. And that is, it makes them feel goofy. They don't like how they feel. They get constipated. They want off of it regardless really of the pain that they may be feeling. Somewhere around 10 of them will have an unusual different reaction. And at least 2 or 3 of them will say this to me, having talked to people like this many years, and that is from the first pill that they had never felt better in their life. They felt euphoria, they felt energy, and wow, that is somebody who is set up for addiction. And when you start looking at the people, well, maybe they had parents who had addiction problems, maybe grew up in an environment where it was really acceptable to experiment with a lot of different drugs. And I also emphasize this, that untreated, we are dealing with a fatal disease. Just like cancer, there's only one way it can go. People will die from it eventually. And as you notice, they include the word disease in there. That's been recognized by the AMA since the 1950s. So I hope we all recognize that when we're dealing with people like this, we're dealing with people with a disease, and it should be approached that way too. Pseudo-addiction, something a little bit different. And we see this every day, again, in hospital settings, and it's tough for nurses, it's tough for doctors, and that is when all of a sudden somebody keeps pushing that pain medicine request button. Well, gosh, are they somebody addicted to this? Are they somebody going through withdrawal? It sure is drug-seeking behavior. But again, I emphasize that if a person's been on these medicines legitimately for some time and for some reason runs out of medicine, you will see them acting like a typical addict. They're begging for medicine because they're withdrawing. Again, doesn't mean that they're an addict, but definitely need the medicine. Okay, this is a map, obviously, of the United States. The thing to take home from this, the darker the color on this map, the higher number of prescriptions that are given for narcotic pain medicine. And as you can see, Indiana is one of those dark states. I've also seen a map of the state of Indiana, 92 counties in Indiana, and there's between 5 or 10 that are the highest prescribers of prescription opiate medication. And unfortunately for us, West Central Indiana, including Vigo County, is one of those very dark counties. So high prescribing of those medicines. Inspect. I hope everybody who's listening today is familiar with Inspect. Inspect's been around really for probably, I'm going to estimate 15 to 20 years, but that the only people who could initially use it was the DEA. So they could track prescribers and people who were receiving these medicines. But in 2007, the state of Indiana authorized that prescribers could also look up patients and look at their controlled substances that they were being given by different people. And unfortunately, it's an underutilized tool. And that is, the estimates are that probably only 30% of physicians have signed up for Inspect, and less than 30% of them actually use it regularly. That may be changing because of the state, Indiana State Medical Association, changing the rules on prescribing chronic pain medicines. And what they have said in that rule is that if you are prescribing a opioid medication to a patient for greater than 3 months, that you are required to do a lot of things, and one of them is to look up and Inspect at the start of your treatment, and also at least once a year. Now, more and more physicians are doing that on every time the person comes in to see them. That way they can keep a pretty good track. I'll interject here the other things that are in that rule, and you can look under the Attorney General's website, you can look under the Indiana State Medical Association, and you very clearly can come up with all the things that you should be doing as of November 6, 2014, if you're treating people with chronic pain. And things like having them sign an agreement with you, that they understand they're taking a medicine that needs to be monitored, it has a lot of side effects, things like that. And they also say that once you reach a certain threshold of a medicine, and that is if you're giving greater than 60 pills a month on any type of opioid, or if you're giving greater than 15 milligrams of morphine equivalent doses, that you are required to do all these things the state of Indiana Medical Licensing Board has said that you need to do. So be sure and make sure that everybody who's prescribing are doing those things. The last sentence in this is, currently Inspect, it takes about a week for pharmacies to put this into their data bank, but as of next January, that's going to happen literally on the day the prescription is filled. The other thing that's happened is that more and more states have done the same type of tracking, and Indiana became the first state to have all the surrounding states around it being able to be accessed by Indiana prescribers. Again, they're estimating by the end of 2016 that literally almost all states in the United States will be on this, and you'll be able to look up somebody who's just moved to Indiana from California. Well, why did the Medical Licensing Board jump in and do something so dramatic? Well, it was because of these statistics that 15,000 people all of a sudden were dying from overdoses of these medicines. And it says here that these combined overdoses from this were higher than cocaine and heroin. But the other thing that it doesn't say here, it really overtook auto accidents as a cause of death, especially in young adults, about 5 years ago. Prescription deaths from painkillers have tripled since 1999. Again, I know a lot of people who are listening today are in rural communities. Unfortunately, rural communities have about 2 times the risk of deaths from overdoses. And again, this is a tremendous number, that last one, but almost 260 million prescription for painkillers in the United States, enough for a bottle for every American. Okay, this shows what happened over the decade of the 2000s, and you'll see The sales of the medicines skyrocketed, deaths skyrocketed, treatment skyrocketed. But I go back to the early 2000. Well, what in the world happened there? Because if we had the previous decade, those were pretty steady numbers, pretty much the same, but something really skyrocketed the use of this. Well, I'm always going to pick on the pharmaceutical companies, but they sure did an excellent job of marketing, narcotic pain medicines and making it more of a reflex thing to do for people who were in pain. But also pick on the Joint Commission of Hospitals that all of a sudden put out the fifth vital sign that is still there today, and that is why we are required to ask each and every patient what pain level they're in, and obviously to do something about it if they say they're in pain. Then I also pick on the Federation of the Medical Boards in the United States. In the early 2000s, here's what they did for physicians. They passed a rule that said, if you have people in pain and you are not treating their pain, then you should be called before the Medical Licensure Board and disciplined if people complained about it. Wow. Now that put a chill through a lot of different physicians. And again, I think all those things in combination, skyrocketed the dose. Again, another way to show it here, and that is the average number of painkiller prescriptions per 100 people. There's Indiana up in the higher numbers, 109. How do you get 109 out of 100 patients? Well, that somebody's getting more than one prescription. And you do see that 2 or 3 different types of opiate medications being used. Statistics in women. Wow. Still to this date, more males die from overdoses of narcotic pain medicine, but that is rapidly coming together. And they say in this statistic, 400% increase since 1990 for women. Of those 15,000 deaths, in 2010, 6,000 of them were females. Almost 50,000 females died in that decade of 2000. The bottom one, I want to emphasize this. Obviously, when you have a female of childbearing age and who gets pregnant who is on a chronic narcotic opiate medication, that means that the fetus, the baby when they're born, is going to go through a withdrawal. And those are the statistics. 300% increase in neonatal abstinence syndrome in that decade. Part of the rule for the Indiana Medical Licensing Board says that if you have a female between the age of 15 and 55, that you have to take time to educate them about what would happen to the fetus if they became pregnant while they're on the chronic opiate medication. That is part of the rule that was passed. Okay, we have said opiate deaths in females, but there's actually other medicines that have been shown to be part of these overdoses. Benzodiazepines, cocaine, heroin, antidepressants, people getting treated for depression. And usually, a lot of times these are combined with alcohol. And I emphasize this a little bit. People who are on chronic opiate medications, and we see this a lot, that they're also given a benzodiazepine for their anxiety. They're given Ambien for their sleep. They're maybe given Soma for their muscle pains. And boy, that is a deadly, deadly combination. And more we're seeing prescribers being educated about that and either not doing it at all or definitely doing low doses if somebody has a legitimate, for example, anxiety disorder. ER visits, again, for females, same type of thing, just showing the tremendous numbers. And that's kind of the age breakdown. Definitely the highest in that 25 to 34, but really basically about the same from 25 to 54. A real telling sign, these are in 2012, the 5 most prescribed medicines in the United States of America. 3 of them are the very same medication, okay, different pharmaceutical companies. So you add all those up for the hydrocodone, you're coming up to, 127 million prescriptions for that medicine, as compared to something thyroid and compared to something for blood pressure. Not all abusers are the same, and this is happening in Indiana, and for the first time in my career, I'm seeing it happen a lot, and that is heroin. Heroin is in Indiana. I've been real fortunate being in Terre, Haute, to be able to say and hold up one hand. The people are here. I guess you guys are seeing me, so I'll hold up my hand in front of you. Okay. I would always say, wow, for 30 years, on one hand, I could count the number of people who were addicted to heroin that I saw. And if I was really truthful, I would say half of a hand. Well, now I kind of do this. And this is happening all over Indiana. And one of the unfortunate side effects of people who were on chronic opiate pills, and as we have now become more stringent in prescribing them.
Code blue endoscopy, code blue endoscopy, code blue endoscopy.
Okay. I don't have to respond to that, so I won't. Okay. But anyway, that they have turned to heroin. And again, these are real smart drug dealers who realize, wow, there's a market for heroin to replace opioid medications. And unfortunately, that's happening, and overdose from heroins have skyrocketed in Indiana. Again, hardcore people, and that is, it takes something a little bit different for somebody to now start injecting needles into their arms. But unfortunately, that happens with people like that. Just going down the list, obviously, of people who have only used pills, people who have used many different substances, the polysubstance abuser who will take literally anything and experiment with them. Inexperienced users, wow, that's a big, big, big concern. Gosh, all of us in this room, have we experimented as we grew up with alcohol before we were 21 years old? Probably the answer, 99%, is yes. But when you start experimenting with something like a narcotic, and we've had it unfortunately in this community, hey, once you try this pill, this will really mellow you out, and you take this narcotic, it turns out to be Oxycontin, and it turns out to be a high dose of it, and all of a sudden now you stop breathing with the first dose you've ever taken. Several years ago, we had a situation where somebody got a hold of fentanyl patches. They cut them, and kids were licking them at some party, and about 3 kids ended up on ventilators here at our hospital. Fortunately, all survived. But point being, that's what can happen to inexperienced users. The patient abuser and addict, I promise you, if you prescribe things, people have come into your office and they have scammed you. They have figured out how to get pills from somebody. And again, in talking to people who have gotten addicted, they would say this type of thing. Well, gosh, we knew our supplier was seeing their physician. I'm going to pick on Illinois since we're close to Illinois. So they went over to Illinois, saw a physician, got their prescription for 300 Oxycontin for the month, never to use one of them themselves, but to sell every pill and make a pretty good profit with that. So there are scammers, no two ways about it. Their system that we talked about with Inspect is part of this national system, the radars. Again, hydrocodone became a Schedule II medicine just a few months ago. The reason being that they finally concluded that the abuse potential for it was equal to oxycodone, Oxycontin, and so they put more rules and regulations. You'll hear Dan talk about the different receptors in the brain, but that a mu receptor medicine that has more propensity to that, such as fentanyl and morphine itself, seems to be abused less often. And a matter of fact, in the treatment of opiate-dependent patients, that's one of the things we utilize, medicines that have that opioid agonist type of approach. The bottom one, boy, this says it all. 80% of the global opiate supply in the world is consumed in the United States of America. 99% of hydrocodone supply is used in the United States of America. 2/3 of all global illegal drugs, United States of America. When you say, wow, what's the number one industry in the world? Number one industry is felt to be probably oil. And number two, probably illegal drugs. But as opposed to the oil companies, you don't see too many ads on TV for the number two global economy. And maybe I'll just interject this. I had the opportunity just in December to hook up with a physician who trained here in Terre, Haute, who's now been in Africa for 15 years, does a lot of different operations. Unfortunately, he's in the Sudan, war-torn country, a lot of amputations. 0 opiate medications he uses in operations like amputations, 0. Has some Tylenol, has some ibuprofen, but people get through it. Wow. Not in this country. Quickly, that obviously the cost of people who are abusing opiates and literally other substances is tremendously high. They say here 8.7. Boy, if from people who have insurance through their employers, boy, if it has a recognized substance abuse problem, wow, users $16,000 a year versus non-abusers $1,800 a year. Number of days work. The total cost of opiate abuse, 2001 was felt to be about $8.6 billion, 2007, $55 billion. Now they estimate about $100 billion. Okay. Just to get people's attention, wow, malpractice claims have gone up. Here for anesthesiologists who treat pain, chronic pain, 3% of the claims in 1980 were malpractice related to pain medicines, almost 20% in 2012. And the number one reason was people dying who were on these medicines. So 6% in the 1980s, 30% almost by the end of 2008. And how about this? It's estimated 82% of claims that at least 70% of the patients were felt to be non-compliant, and ended up dying. And probably another 60% were felt to be probably not quite managed right by the physicians. So there's actually been a few tools that have been developed. Well, how knowledgeable are people in prescribing these medicines? And so here was a little study that they assessed in Pennsylvania, and they basically found that less than 50% of the respondents, the physicians, were able to correctly convert opioids. 46% of residents who correctly converted them were anesthesiologists, which is nice. But that means 54% of them didn't know how to convert them. And this ties into a little bit with the Indiana Medical Licensure Board when they said to physicians, boy, you have to follow these rules. Once you get up to a equivalent dose of 15 milligrams of morphine a day, and I've been in a room of 200 physicians, and the question was asked, how many of you in your head can calculate that dose? And I've seen 2 hands go up. So that means that you have to get on a computer and have some kind of tool to make that calculation to figure out what dose you're given. And that the concerning thing was not knowing how to dose these things, added to respiratory depression, trying to figure out who was tolerant and what might happen to people who were on ventilators. So I'll turn it over to Dan right now. He's going to go through a little bit more detailed on the medicines. Thank you.
Good morning. So yeah, Dr. Stevens, I was just going to tie on to the question there about tolerance from the previous slide. I just want to share with the room and people out there, opioid tolerance is defined today by 60 milligrams of oral morphine daily, 30 milligrams daily of OxyContin, 25 mics an hour for the fentanyl patch, 8 milligrams a day of Dilaudid. That's tolerance. And what we found even with the Pennsylvania survey and our own survey that we administered to the hospitals contributing to this was most of the respondents, about 60% of the people got it right. So it's still, I'm glad 60%, and the highest number was physicians, so that's good. But unfortunately for pharmacists and nursing, we were the lower on the echelon. So we got some work to do there with education. So I just wanted to share that. Obviously opioids, they are the mainstay, and they are defined by the receptors they work at, mu, kappa, delta. They're all classified by their activity on the mu receptor, as Dr. Stevens alluded to, with ranging from strong, weak to partial, which I'll talk about that more in detail here in a minute. And then your mixed agonist / antagonist, those are agonists or partial agonists at the kappa receptor and typically have antagonistic activity at the mu receptor. So a lot of these agents aren't used with regularity anymore, but if you do use these, like for example, nalbuphine or Nubain, in someone who is opiate tolerant or dependent, you can precipitate withdrawal. We use a lot of Nubain here in the hospital in certain cases. A lot of our OB patients who unfortunately take a lot of hydrocodone as an outpatient. And then your antagonist, obviously naloxone, Narcan, and a couple of other alternatives there as well. So I think everyone has a pretty good handle on the pharmacological effects as related to analgesia, euphoria, sedation, etc. I also think most people have a pretty good handle on the adverse effects. But what we've noticed over the past 2 years here at Union Hospital, the respiratory depression, the hypotension, we've seen a significant number of increases in our rapid responses. And a number of them are attributed, frankly, to errors or dosing errors or just frequency accumulation doses with hydromorphone or Dilaudid. So internally, what we've done, because we had a lot of issues with 2 milligram IV doses being fairly common, we have eliminated and capped our dose of IV Dilaudid to 1 milligram. Removed anything over 1 milligram from our inventory, and actually we've taken it a step further and have reduced it down to 0.5 milligram. So if a nurse is going to give a 1 milligram dose, she has to pull 2 vials, with the hope being that she triggers herself to think, maybe I shouldn't give this second dose. That seems to be a high dose. So I know a number of places are facing that. And frankly, a lot of it has to center around, patient comes to the ER, they get their dose of hydromorphone in the ER, they go to the floor. Sometimes systems don't communicate. Nurse doesn't know they got that 2 milligram dose down the ER. We give another dose upon admission to the floor. So we're working internally to change a lot of those things. So classification, so there's your definitive list. Obviously, no surprise there. The weak full agonist, hydrocodone, I think we could probably make an argument. That one probably needs to be moved up to full agonist just because of the abuse potential we've seen with it over the past 15, 20 years. And recently with its move to a Schedule II substance. Partial agonist, and I'll let Dr. Stevens, and I know Dr. Turner's in here, I saw him earlier, talk about buprenorphine. This agent has kind of revolutionized treatment for people with addiction issues. Historically it's been methadone that's been the primary agent we've used. Buprenorphine or Suboxone or Subutex. Suboxone is when it's combined with naloxone. You do have to be registered to dispense this for addiction issues because of the Drug Addiction Treatment Act of 2000. With that, you get the specialized DEA number with the X in front of your DEA number. But ironically enough, you do not have to be registered to dispense it for pain. It is a Schedule III substance. For us, so obviously it has high affinity for the mu receptor, low intrinsic activity for that. So what that tells you is it will treat analgesia. You don't get the euphoria, the addictive properties that drug has. So from a pain standpoint, and I know it's got such a stigma with it that a number of physicians probably don't want to use it off-label for pain, but from a pain standpoint, it's probably a pretty good agent. And the addictive potential of this agent is pretty low. I will let Dr. Stevens and Turner field questions about that and their experience at the end of the presentation. And then again, there's your agonist, antagonist. And like I said on the previous slide, you get some more kappa receptor activity here and maybe even some of the delta receptor activity. So butorphanol, anecdotally, had a number of people, I'm from the Vincennes area, had a lot of physicians back in the late 80s, early 90s who got some patients started on butorphanol or Stadol. And I don't know if you guys have any experience with this, but the euphoria and dysphoria with that agent was pretty profound. Had a lot of patients who really struggled to get off of that agent. I don't think it's used much anymore. It was used a lot for migraine headaches back in those days. So we have better agents now. But anyway, so the dysphoria component with those drugs sometimes can be problematic. Breakthrough pain. On the inpatient side of things, sometimes we, as pharmacists and our clinical staff, we're asked to do some dosing conversions and figure out dosing. So I just include this just kind of a refresher slide when you're thinking about how to dose for breakthrough pain instead of maybe having to take a best guess. Typically, it's supposed to be 10 to 15% of their long-acting dose PRN. A lot of times we see patients who are on multiple agents, oxy-IR versus another agent for their breakthrough pain. Ideally, we would like to see patients be on both the immediate release, if available, and the extended release agent and be the same drug. So I just have an example there at the bottom of the slide, kind of how you would go through that cacalculation. And again, this is just kind of a guesstimate. Obviously, every patient's different depending on the duration that they've been on pain meds and their tolerance. You can go higher, but a lot of times what we'll see is, 40 milligrams BID for their maintenance medication, and then see 20 to 40 for breakthrough. And then all of a sudden we're having issues with respiratory depression, patients heading towards a code, et cetera. So I just wanted to share that. Dr. Stevens had talked about this earlier as well, opioid conversion. So we see this a lot, new pharmacists, new nurses, new medical residents, and how to come up with calculating that total daily dose of opioids, especially when switching from one agent to another. The next slide I have included is an Equianalgesic dosing table. They're readily available, but like Dr. Stevens mentioned, for whatever reason, a lot of people really don't like to use these and kind of like just to take their best guess at it. One thing to keep in mind too, when you do calculate that total daily dose from the agent they're on to what you're switching them to, typically it's recommended to reduce that dose by 50% to account for incomplete cross tolerance. Again, it depends on the patient, but that's kind of a best guess. So on this slide here, I'd just like to highlight a couple things. Most people, I don't think, really truly understand that when you're comparing morphine to hydromorphone, 1 milligram of hydromorphone is equal to 7 milligrams of IV morphine. And so what we've struggled with over the last few years, patients get 2-3 milligrams of IV hydromorphone who are opiate naive. I mean, most physicians I've not seen historically start off someone, 10, 15 milligrams of IV morphine. So I just like to highlight that and make sure people are aware of that. Now, the difference between going from IV hydromorphone to oral hydromorphone is the oral bioavailability of hydromorphone is not as good, is not as important. So you can get to larger doses of oral hydromorphone and not have maybe the risk you have with the injectable version. And so there is broken down for you just kind of a table to summarize kind of what that looks like when you're making these conversions. And like I said earlier, 0.67 milligrams of hydromorphone equals 10 milligrams of morphine or 3.3 milligrams IV. And then the oxycodone component, because we do have a number of patients in the Vigo County area and surrounding areas who are on gigantic doses of oxycodone as well. And so when you're dealing with those patients, it can be very problematic trying to convert them from their oral dose of oxycodone to what their IV dose of the other agents would look like. So I just wanted to share that with you guys for your reference. And then, as Dr. Stevens also alluded to, the growing problem with fentanyl patches and the doses that some of these patients are on. So I just kind of wanted to show this for your patients who are on over the 150 mic patch. I've seen a number of them with 300 who have patches all over their body. That theoretically is what you're looking at from what they would equivalently need to be converted to oral morphine wise. Now, obviously, we don't see these kind of doses. I've never seen one take that much of the 300 be converted successfully to oral morphine, but those are the numbers you would be looking at if you had to convert someone from those kind of fentanyl patches back to oral medications, which is obviously a very staggering number. A new product that hit the market here recently, I just want to share with you guys if you're not aware of it. Zohydro, or extended release hydrocodone. I guess the good news about this is they didn't combine it with acetaminophen, so you don't have to worry about the risk for acetaminophen toxicity. The bad news is look at those doses, 10, 20, up to 50 milligrams of hydrocodone. It is very difficult to get registered for this product. I talked to a couple of pharmacies yesterday. There is one CVS in town who is registered to dispense it. I would imagine Walgreens has one as well, probably a Walmart here or there. But in Terre area, I believe there's only 3. So you do have to be registered. Does anyone have a patient on Zohydro, just out of curiosity? Ever seen it? No. So the patient has to sign a contract with the physician, present it to the pharmacy, and then the pharmacy has to fax it in to the company because they're in an ongoing REMS study to track the safety, efficacy, et cetera. But again, reserved for, I think, people who have struggled, who are opioid tolerant. I would not start anyone opiate naive on these products because, again, the dose of hydrocodone, that 10 milligram for the currently available products, that's the highest dose of hydrocodone you can give with Norco, et cetera. So controversial how it got to the market. As you can see there, a lot of states fought to not get it approved. Unfortunately, the FDA won on this one for whatever reason, so they pushed it through. Sales are increasing. I talked to the CVS at 9th and Poplar yesterday. He dispenses probably 20 to 30 of these a month. Now, I will say that CVS dispenses probably 600 scripts a day, so it's a very busy CVS. So percentage-wise, it's not significant, but it is growing. Interestingly enough, also, a 30-day supply of this for 20 milligrams a day, cash-paying customers, $500. And he actually has had a few people who are cash-paying customers who will buy this and pay it. So what's that tell you? Probably what they're doing with it. If they can afford to spend that $500 to get it, probably diversion to the streets. So again, they did put some plans in place to make it abuse a deterrent. However, it seems to be that people are going through those steps to dispense this medication. Dr. Stevens also mentioned this a little bit. Hydrocodone did finally move to C2 in October. Nationwide, scripts are declining, but in the Terre, Haute, Southern Indiana area, they are not. And actually, I talked to the same pharmacist at CVS. He has not noticed 1 ounce of decrease in his hydrocodone dispensing numbers since they implemented this rule. Now, the paperwork involved with it is a lot worse because you can't do refills, et cetera. But the quantities and the number of scripts filled are not diminishing. Tramadol, Ultram moved to C4 last year as well. Again, that one kind of surprised me because I'd never historically seen abuse be that high with Ultram, but apparently a number of people were concerned with this, so it did move to controlled substance. And then in November of 2014, Indiana passed emergency rules banning the compounds used in synthetic drugs for the K2 and spice. And I actually looked at those products and their chemical names that I can't begin to pronounce, but not readily accessible for the average person. So risk factors for opioid abuse, no shocker here. Greatest when there's over 3. And unfortunately, in all the hospitals that we're talking to today, we all face all these issues with these patients. Socio-demographic issues, pain, drug-related, the alcohol and substance abuse is extremely significant in our community, and all that sets you up for people who are going to be high risk to abuse opioids. And again, anecdotally, from what I've seen when I worked retail pharmacy, everyone you dispense these to chronically fit almost all of those categories right there. And the genetic component, like Dr. Stevens said earlier, very, very strong, very strong. So methods to avoid abuse, he talked about inspect. There are a number of other tools available as well. And that last bullet there, the regulatory measures, the REMS, again, this is required for Zohydro. It's also required for Suboxone and a number of other agents out there. So the FDA is finally holding people accountable for this, tracking what the safety and the dispensing numbers are. So that is growing. It seems to be growing for any new extended release product that hits the market or being required to submit regulatory information for REMS. So prescription drug monitoring programs. There is a global shot of what United States shot of what you're looking at. Missouri is the only one who currently doesn't have anything in force right now. Legislation is pending for them. Indiana, I am proud to say we were kind of in the forefront with this to get on board, probably because we have a large problem with this. But as you can see, it is growing, and with the hope being soon that we will be able to share nationwide. So currently 31 states will share with Indiana information. You can go run reports and find with 31 different states, 35 hopefully by the end of this year, with the hope being by the end of 2016, almost all 50. So I think it should be a federal law. It would make it very easy. And Dr. Stevens talked about earlier, you are required at a minimum to submit every 7 days now, and beginning next January, do it real time. I will say a number of pharmacies, the retail chains have already done this. CVS and Walgreens do real time today, I found out yesterday. So a lot of people are being proactive with that, and a lot of people really utilize those reports when dispensing to patients. And so that's kind of what it looks like as far as across the nation where we're headed with the PMP Interconnect. So just a little summary slide there with some news over the past year of what you're looking at. Alarming enough, and we're starting to see this a lot more too, is the increase in use of the adolescent, teenage, college-age student who now figured out there's no need to take the risk for illegal drugs when prescription drugs could be just as good, if not more or better. So again, you see a big increase on this number of ED visits. I would like to pull Dr. Tusi to find out how many ED visits we have from Indiana State University students who are coming in who have experimented with these medications. It's troubling. So this summary, opioid abuse is a growing burden on the healthcare system. Obviously the deaths, litigation, et cetera, have a huge economic impact on the healthcare system. Recent studies have indicated that we do need to increase our education to our healthcare professionals, pharmacists, physicians, nursing. All of us, unfortunately, don't have a real good handle across the board on what we're dealing with and how to appropriately dose and convert these patients to different medications. Luckily, we have implemented some laws with hydrocodone. I do feel like it's a little bit too late on that one. And then the prescription drug monitoring programs, I think, are going to be an excellent tool if people will use them. That's the big key with this, if you will use them. I think they're a very valuable asset, because in the old days when it only went through on insurance companies, you could only track those that were adjudicated. Well, now with the PDMPs, you can track everyone who's paying cash and that's going through third parties. So there's no one that gets through the cracks anymore with that. So there's some do's and don'ts. And on the do side of it, one piece I think that we need to do a better job of is talking with patients about the realistic benefits and what their realistic hope can be for their pain control. I think a lot of patients have an unrealistic view that they're going to be completely pain-free. And so I think that's a big problem. So we keep escalating doses to make their answer be, finally, I'm not in any pain at all, but then you set them up for tolerance and dependence issues. And with that, I'll turn it over to questions for the crowd.
Can you open it up so that the other can ask questions?
Just your escape key, those thumbnails or something like that.
So how do I turn the volume back on?
Oh,
okay. Any questions from anyone out there?
Okay, go ahead.
Yeah. When I have a patient that's on opioids and I do the drug screen, and it comes back showing he or she's not taking the drug, what should I do then? Do I kick him out of the practice? What's my legal liability? And how should I handle this legally?
They're not taking it.
Did you guys not hear him? Go ahead, Dr. Swain.
Yeah, we're not taking it by the result of a negative drug screen.
Yes, what do we do with the patient? Kick him out of the practice or try to work with them or have him back in and counsel them? How do you handle it? When they're non-compliant, they're not taking, you have a negative drug screen, somebody you know is taking the drug.
Yeah. A negative drug screen is very concerning, no two ways about it, if you're prescribing the medicine to them. I always say this, don't automatically kick people out of your practice, but you can clearly say to them, you will no longer be prescribing those medicines for them. Now, if they choose to leave, then that's okay. And you can talk to them about, boy, did they run out of medicine? Were they overusing it? And all of a sudden, are they showing any type of withdrawal? Now, are they buying something off the street? Again, if there's a problem, you can try to help them get into treatment. But I always say, don't necessarily kick people out of your practice that have problems. You see if you can work with them to get them through this. And so that would be my approach with that person.
So you would not prescribe the drug anymore?
No, I would not. Yeah, if you clearly had the screen that showed that there was nothing there, it would be over and done and prescribing the medicine.
Thank you, Randy.
Yeah.
Can you ever see drug screens that you don't trust?
Okay. The question here, do you ever see drug screens that you don't trust? And the answer is yes. Yes. And so one of the part a little bit was that I assumed that the drug screen was one that was sent on for confirmation. And so you never just act upon a screening test. Never, ever. That, and a matter of fact, the Indiana Medical Licensure Board, their rule is if you do the test, you are required to send it on for confirmation because they don't want people acting on it just as a screening method. Too many false positives, too many false negatives. If you get back a gas chromatography type of analysis, you can be pretty confident in that, of what is truly in that urine. So, any more questions?
My name's Dr. Richard Henchman, and I'm a fellow of the American Society of Addiction Medicine. I monitored pharmacists for the state of Indiana for about 10 years, and I want to comment on drug screening. I've had patients many patients who were able to beat the drug screen. I had one nurse who would go into opiate withdrawal for about 5 or 6 days, and then store up some urine and freeze it so that anytime she was called, it would be a negative screen. And I found out a couple years later that she had been using buprenorphine. After a while, I began to look at drug screens as an IQ test. But I guess my comment is you can't necessarily, if you have a strong suspicion that somebody should have a positive drug screen and it's not showing up, you may want to consider some alternatives such as hair testing. Any comments on that?
Yeah, definitely a good point, and that is I'm the chairperson for physicians in Indiana, and we do hair testing, on them, not every time, but over the course of a year. Instead of giving a urine, we might do a hair test on them. So yeah, hair testing is very acceptable, correct. And people will always figure out ways to beat a system. No two ways about it. And I'm over at an occupational health clinic now where we do about 50 drug screens a day. And I promise you, in the course of a day, you see some very, very interesting situations. We find results of condoms that had urine in them left in waste baskets and things like that. Obviously, people use warmers to warm up what you were describing there, that frozen urine, trying to get it to body temperature. And people come in and their urines are 110, or more commonly, they're 80 degrees. Obviously didn't come from a human being at that moment. So yeah, people will always be able to try to beat a system, including physicians, I'll say. Well, thank you. Appreciate everybody being here today, and let's try to help deal with this problem. Thank you.
Thank you.
Thank you. Hey, Joe,